Sally to begin.
Okay, good afternoon, good morning to everyone who is joining us. If we could go to the next slide. Yes, thank you. Sorry, before that one. My name is Sally Zweimuller. I am a dissemination specialist with the Demographic and Health Surveys program. Today, I will be the MC for today's virtual dissemination webinar for the 2018-19 Uganda Malaria Indicator Survey. I'd like to start with some expectation setting and a comment about our current situation. The COVID-19 pandemic has quickly changed our world. Our professional and personal lives have been greatly impacted. Amid the stress and anxiety, we hope that you and your family and colleagues are staying safe and healthy. The COVID-19 pandemic has required us to make some changes. Originally, we planned to disseminate the 2018-19 Uganda Malaria Indicator Survey at an event in Kampala with the malaria community and media. Today, we all join from different locations around the world, in front of our laptops or our mobile phones. We, the National Malaria Control Division, the Uganda Bureau of Statistics, PMI, CDC Uganda, and the Demographic and Health Surveys program want to show our appreciation to everyone joining us from home today. Thank you for your focus and your commitment. We too have been working from home to get this webinar to you today. So please have patience with any audio glitches. As a reminder, please turn off your microphone and your video capability. That way we can ensure that everyone is able to see and hear the webinar today. Now we will move on with the program. First, I would like to introduce, just so you get an understanding of what we will be doing today, we will have a few speeches from the NMCD and the Uganda Bureau of Statistics and PMI Uganda. And then we will have a presentation of the key findings from the 2018-19 Uganda Malaria Indicator Survey. And then we will have a Q&A session. So throughout the presentation, you can please put your questions in the chat box. I'm going to begin introducing Dr. Jimmy Opigo, Assistant Commissioner of the Uganda National Malaria Control Division. Dr. Opigo served as the Principal Investigator of the 2018-19 Uganda Malaria Indicator Survey, or UMIS, and is responsible for the oversight and implementation of malaria control activities in Uganda. Let's welcome Dr. Jimmy Opigo.
Thank you, everybody, and welcome.
Thank you, Jimmy. We can hear you.
Greetings, everybody. Today, I have the great honor to represent the Ministry of Health and the National Malaria Control Division in the launching of the 2018-2019 Uganda Malaria Indicator Survey. Welcome all our distinguished guests. I would also like to thank the donors who supported this survey, specifically the USAID, the President's Malaria Initiative, that's PMI, the United Kingdom Department for International Development, DFID, Government of Uganda with Global Fund support, and the World Health Organization. These agencies' continued support of the Government of Uganda allows us to continue improving the health of Ugandans. I would like to thank the ICF for providing the technical assistance in conducting the survey. The Uganda Malaria Indicator Survey is one of the key performance monitoring tools that are periodically used to provide an in-depth assessment of malaria over time. This is the third survey undertaken with support from USAID and PMI. As you know, the previous two were in 2009 and 2014-15. In order to ensure that our programs are working and that resources are allocated in the best way possible, monitoring and evaluation of malaria programs is very essential. Data from surveys such as the Malaria Indicator Survey is one mechanism to provide evidence in the reduction of sickness and death caused by malaria throughout Uganda. From 11th December 2018 to 31st January 2019, 23 teams of interviewers traveled throughout Uganda, visited households, interviewed women, tested children for anemia and malaria. Refugee settlements selected in some districts were also included as a separate domain. We are grateful to these hardworking teams who carried out this enormous task and made sure that accurate data were collected and recorded. The results of the 2018-2019 Uganda Malaria Indicator Survey will be used by Government of Uganda and the Ministry of Health to inform priorities, strategies for malaria prevention and its eventual elimination. As you are aware, we have started using even before this official commissioning. We have already used to inform our malaria program review, our strategic plan, and the GF application. I encourage you all to do the same. We need to continue using the data. Finally, I would like to give special thanks to all the people at Ministry of Health, NMCD, UBOS, all our partners, especially those who have even managed to join now, Malaria Consortium, PSI, TASO, Vector Links, CDFU, Rotarian Malaria Partners, MASIS, and all of you. Thank you, and we look forward to a fruitful dissemination. Thank you all, and out.
Thank you, Dr. Apigo, for those very thoughtful welcome remarks. Our next speaker is James Muwange, Director of the Socioeconomic Surveys from the Uganda Bureau of Statistics.
Hello, greetings to everyone. Protocol observed. I would like to take this opportunity also to welcome you and to make a statement on behalf of the Uganda Bureau of Statistics. On behalf of the Uganda Bureau of Statistics, we also want to join you to congratulate you on this occasion when we disseminate the Uganda Malaria Indicator Survey 2018-19. The findings, which are going to be presented today, are based on the results of the survey that we undertook from December 2018 to January 2019, as Dr. Jim Apigo has elaborated. This was the third survey, with the first one having started in 2009. But along the way, the demographic and the survey has also been complementing the efforts of the Malaria Indicator Survey. The main objective of the survey was to obtain population-based estimates on malaria indicators, including prevalence of malaria and anemia, mainly to inform strategic planning and program evaluation. The survey collected information on various aspects of the household, including characteristics of the household, and the women, malaria prevention, management of fever in children, and anemia, and malaria in children, in addition to malaria knowledge. The Malaria Indicator Survey had a national coverage, and estimates are reliable at national level and also sub-national level, including the rural-urban divide. As a bureau, would like to to thank the various organizations that contributed to the success of this survey, both financially and technically. And these include the DFID, USAID through PMI, the WHO, and the Global Fund through the Ministry of Health. We thank you for your effort and for ensuring that you support the role of statistics, or statistical production in Uganda. Lastly, I wish to register our appreciation to the field workers, to add my voice to Dr. Pigo, who traversed this country collecting the information, because without them, perhaps we would not be here to share what we are about to receive this day or this afternoon in the case of Uganda. To the local governments, we shall always be grateful for your unwavering support towards statistical production. We wish to thank UBOS, the Ministry of Health as well, and the users of data. And we appeal that you undertake more detailed analysis of this information so that you provide more insights into the plausible explanations of the findings which are about to receive. This is critical as it helps us plug the information gaps that may be perceived by some sections of the wider public, and also will help to preempt speculation. This kind of analysis is expected to help us to assess and monitor and to review programs and various interventions and initiatives. Finally, I wish to commend the Ministry of Health and other stakeholders for the confidence they have in the Bureau by allowing us to implement the survey, and we promise that we shall continue to work closely with you to provide the necessary support in undertaking the different initiatives. I will end by emphasizing that timely and extensive dissemination of survey findings is very essential, as it makes the application relevant, and much more so, it is a very good accountability tool. I thank you all.
Thank you, James Mwange, for providing insight on the importance of the data collection and timely data use. Your appeal for analysis of the survey is timely, as the data set for the UMIS 2018-19 Uganda Malaria Indicator will be available during this webinar. Next, I would like to introduce Dr. Mam Niha, Resident Advisor for the President's Malaria Initiative, CDC Uganda, to provide technical remarks.
Thank you very much, Sally. I'll keep this very short. Good afternoon and good morning, colleagues and partners. It's a real pleasure to be here virtually for this release of the 2018-2019 Uganda Malaria Indicator Survey. Just wanted to say a few quick words on behalf of development partners who contributed to this survey. As you know, this has been several years in planning and represent the combined efforts of technical experts from the NMCD, UBOS, the United Kingdom Department for International Development, or DFID, the Global Fund, the World Health Organization, and the US PMI, which I'm representing here today. As you know, PMI is an interagency collaboration between USAID and CDC, and our work in Uganda is to decrease malaria morbidity and mortality by promoting effective approaches in malaria prevention, timely and correct diagnosis, and prompt and appropriate treatment towards the long-term goal of malaria elimination. And this goal, as well as policy and program decision, are really based on evidence and quality data. And when they are based on quality data, they're far more likely to succeed. And this is why PMI, in line with WHO's recommendation to make surveillance a core malaria intervention, has made the collection and use of quality data a top priority. This 2018-2019 Uganda MIS provides decision makers in the government of Uganda and the Ministry of Health, the National Malaria Control Division, and our development partners with this reliable and up-to-date statistics to relate to malaria reduction in Uganda. And we are very lucky that in Uganda, we've had a very impressive record of seeking up-to-date quality data through regular assessment. My colleagues have said this before me, that this is the third MIS that is supported by PMI. But in addition to that, through technical assistance from the Demographic and Health Survey Program, the DHS program, we've had 6 demographic and health surveys and 2 AIDS indicator survey, and as well as 1 service provision assessment in Uganda. So we have many opportunity to study trends from this survey and allow decision makers to monitor progress towards the Sustainable Development Goals and NMCD's Malaria Strategic Plan. So this 2018-2019 MIS cover various topics, from household ownership of insecticide-treated nets to the prevalence of malaria in children. And you will find a wealth of interesting and useful facts in the final report that includes estimates within urban and rural residents, 15 regions, as well as refugee settlements area. The results shows us both successes and a few challenges. For example, although 1 in 8 in 10 Ugandan households have at least 1 insecticide-treated net, we have room to grow when it comes to net use. On the bright side, more pregnant women are receiving intermittent preventing treatment in pregnancy for malaria. And the big news is that malaria prevalence among children has decreased substantially. I won't spoil the news, but you will see that as we go to the findings. So these are just findings, just a sample of what you will hear today and what you will read in the final report. So I'll just end by echoing my colleagues in thanking all the people and organizations who work so hard to make this survey happen. The Uganda National Malaria Control Division, or NMCD, and the Uganda Bureau of Statistics, UBOS, have managed every step of this survey, from the initial planning to training, to data collection and data entry, and writing the final report. Their work has been really exemplary, and they should be really congratulated for that. Thank you, ICF and the DHS program, for your technical assistance through this process and for facilitating this webinar. And thank you so much to Global Fund, DFID, and the WHO for their invaluable contribution. And more importantly, thank you to the survey teams, the interviewers, and the more than 8,000 women and 8,000 households who were respondents in this survey. Thank you very much for your attention.
Thank you, Mom, for providing technical remarks for the UMIS dissemination webinar. Next on our agenda, we will have a key findings presentation for the 2018-19 Uganda Malaria Indicator Survey presented by Bosco Agaba, epidemiologist and diagnostic specialist from the Uganda National Malaria Control Division. Bosco also served as the National Malaria Survey Coordinator for the 2018-19 UMIS and served on the technical oversight committees for the 2 previous MIS surveys. Bosco, I hand it off to you.
Thank you very much for the introduction. I'm sure many of you have been waiting for these results, and we are happy that you are here today for the dissemination. I'm going to provide an overview of the key findings of the 2018-19 Uganda Malaria Indicator Survey, which is actually a survey because most of you participated in this survey. Throughout the webinar, you can post your questions in the chat. The NMCD will address your questions during the Q&A session following this presentation. So I'm having a small challenge with the change of slides, but it's fine now. So the 2018-19 Uganda Malaria Indicator Survey was implemented by the National Malaria Control Division, the NMCD, and the Uganda Bureau of Statistics. And of course, the biomarkers were done by the Infectious Diseases Research Collaboration, IDRC. Financial support for the survey
Bosco, we lost you. Are you able to?
just some small disconnection. I'm back now.
Okay.
Financial support for the survey was provided by the United States Agency for International Development, USAID, through the President's Malaria Initiative, the United Kingdom Department for International Development, DFID, the government of Uganda with Global Fund support, and the World Health Organization. ICF provided technical assistance through the DHS program, which is a USAID-funded project offering support and technical assistance in the implementation of population and health surveys in countries worldwide. So, as you all know, the 2018-19 Uganda Malaria Survey is designed to provide sorry, some small disconnection. I keep breaking off, you'll bear with me. So the 2018-19 Malaria Indicator Survey is designed to provide up-to-date estimates of basic demographic and health indicators related to malaria. The 2018-19 MIS is the third Malaria Indicator Survey to be carried out in Uganda as part of the demographic and health surveys, or which the one we call DHS program. The 2018-19 UMIS provides estimates at the national level for urban and rural areas for each of the 15 regions in Uganda, and for 15 current and 11 past indoor residual spraying intervention districts. Refugee settlements in 9 northern and western districts were included as separate sampling domain. So as you realize, this was very unique for this survey, especially the increase in survey regions from the previous 10 to 15, and the special consideration, of course, to oversample in IRS districts that we believe provided better estimates for the MIS key indicators. In this survey, a total of 8,351 households and 8,231 women aged 15 to 49 were successfully interviewed in the 2018-19 survey. And this represents a response rate of more than 99% for households and 98% for women. Among refugee settlements, the response rate was greater than 99% for households and 99% for women. So this is very important for any survey, and we must thank the implementers and the participants for such a high success rate in terms of response rate. So currently, 83% of households in Uganda have at least one insecticide-treated net, which we call ITN. Household ownership for ITNs is highest in West Nile, which is at 92%, and lowest in Karamoja region, which is at 58%. 78% of households in refugee settlements own at least one ITN. And I'm sure there is a very good discussion. There must be a very good discussion here considering the high net ownership in West Nile and Busoga region versus what we are seeing in terms of malaria burden in those specific regions. ITN ownership has increased slightly since the 2016 UDHS, when 78% of the households owned at least one ITN. However, taking the 2009 MIS as our baseline, we see an increasing trend in terms of ITN ownership, with a peak at 90% in 2014 MIS. For your information, an ITN is a factory treated net that does not require any further treatment. The definition of an ITN in surveys before 2016 Uganda Demographic Health Survey included nets that had been soaked with insecticides within the past 12 months. So from here, you can see that the majority of ITNs, about 91%, were obtained from mass distribution campaigns, such as the one that we are trying to implement now amidst challenges due to COVID-19. Another 8% of ITNs came from routine antenatal care, ANC visits and shops. So from here, I think it's important to note that nets given through ANC provide a replacement mechanism for the old nets. And you may also want to know that the 4% in the private outlets shows that the private sector is actually still an important source of nets. We also measured access, and access to an ITN is a calculation of the proportion of the population that would sleep under an ITN if each ITN in the household were used by up to 2 people. 72 of the household population in Uganda has access to an ITN, and 59% of the population slept under an ITN the night before the survey. Both indicators have increased slightly since the 2016 UDHS. At this point, I'm sure you may want to correlate between the figures between what we saw on the previous slide on ownership and this slide on utilization. Remember, we saw the overall ownership was 83%, and we see that utilization is 59%. So we may have to correlate those figures and generate a discussion there. Children under 5 and pregnant women are the most vulnerable groups to malaria. 6 in 10 children under 5 and 65% of pregnant women age 1549 slept under an ITN the night before the survey. Use of ITNs by both children and pregnant women has decreased since 2014. 2015 MIS and has stagnated since 2016. And I think this could make a strong case for SBCC to enhance intervention uptake. We also measured malaria in pregnancy, and malaria during pregnancy contributes to low birth weight, infant mortality, and other complications. To prevent malaria, it's recommended that pregnant women living in Uganda should receive 3 or more doses of SP during their pregnancy. In this survey, 89% of pregnant women received at least 1 dose of this intermittent preventive treatment, or what we call IPTP, while 72% of women received 2 or more doses, and only 41% received 3 or more doses. Pregnant women receiving at least 3 doses has more than doubled from 15% in 2016 to 41% in 2018/19. So you can see that we are still doing very well on IPTP1 and IPTP2, but not very well with IPTP3. The other indicators we looked at were in interventions related to case management. And we all know that fever is a major symptom of malaria in children. In Uganda, mothers were asked if their children had any fever during the 2 weeks before the survey, and if they sought medical help. Currently, we saw that 87% of children with recent fever had advice or treatment sought, a slight increase from 81% in 2016. Half of children with recent fever had taken blood from a finger or heel for diagnostic testing. Treatment seeking for children with recent fever has slightly increased from 81% in 2016 to 87% in 2018. Diagnostic testing has increased from 17% in 2009 to 51% in 2018, stroke 19 MIS, the one we are presenting today. So important to note here is that our strategic plan targets for treatment and testing is at 95%. So clearly we can see that we are operating slightly below the targets. In terms of artemisinin-based combination therapy, which we call ACTs, which is the recommended first-line anti-malaria for treatment of uncomplicated malaria, we saw that 88% of children under 5 with recent fever who received an anti-malaria took an ACT. But of course, it is important to note that we still see other types of monotherapies that are still on market, though in very small proportions. All children under 5 years of age living in selected households were eligible for anemia and malaria testing. Anemia testing was carried out using the HemoQ system. Malaria testing was done through both rapid diagnostic testing, known as RDTs, as well as blood smear microscopy. Of the 7,311 eligible children, around 97% provided blood for anemia testing, RDT, and malaria microscopy. In this survey, we saw that 4% of children under 5 years have low hemoglobin nationally. The prevalence of low hemoglobin ranges from a low of 1% in Toro region to a high of 13% in Karamoja. 3% of children in refugee settlements have low hemoglobin. So when you refer to the detailed report, you will see what we defined as low hemoglobin. The other biomarker that we measured was parastemia in the study population. And in Uganda, 1 in 10 children under 5 tested positive for malaria by microscopy. Malaria prevalence varies greatly by region, ranging from 34% in Karamoja to less than 1% in Kampala and Kigezi region. In refugee settlements, 13% of children under 5 tested positive for malaria by microscopy. This, of course, correlates well with what we see in routine DHIS2 in terms of burden. Again, one may want to look at how the different interventions correlate with parasite prevalence and transmission patterns. So here we see that prevalence has decreased from 42% in 2009 to 19% in 2014/15 MIS, and now to 9% in this survey of 2018-2019. I remember in our discussions during the strategic plan, we were so ambitious and we want to lower this curve further by the next MIS. Among the children who tested positive for malaria, 97% had the prevalence of Plasmodium falciparum infection, 10% had Plasmodium malariae, and 2% had P. ovarian infection. However, 9% had mixed infections. Among refugee settlements, 13% of children aged 0 to 59 months were positive for malaria parasites, according to microscopy. Among children in refugee settlements who tested positive for malaria, 99% had the presence of P. falciparum infection, and 1% had the presence of P. malariae. So clearly we can see that falciparum is still a predominant species in Uganda. However, important to note here is the increasing prevalence of Plasmodium malariae as compared to the previous surveys. In terms of SBCC, the majority of women aged 15-49 know that malaria is caused by mosquitoes, stroke mosquito bites, about 78%. Another cause of malaria mentioned by 15% of the women is not sleeping under a mosquito net. So, and 14% not the presence of standing water or breeding environment. So the most common way to avoid malaria cited among women aged 15-49 is sleeping under a mosquito net, which is about 91%. 22% cited keeping the surroundings clean and destroying breeding sites. Among women aged 15-49 who have heard of malaria, 39% have seen or heard a message about malaria in the past 6 months. Exposure to malaria messages is higher in urban at 43% compared to rural areas at 38%. It is, however, lowest in refugee settlements at only 16%. So you see, BCC, I think, still has a case to front in terms of and access to messages. So as you see, the 2018-19 Uganda Malaria Indicator Survey provides a wealth of information about malaria in Uganda. And please note that all materials, digital tools, and datasets with MIS data are now publicly available online at dhsprogram.com. So this includes the final report dataset, atlas, and fact sheet. Links to the publications and datasets will be shared if you provided your registration information. Additionally, the DHS program has digital data use tools with 2018-19 UMIS data, Start Compiler, and the DHS program mobile app, free for download in your app store. Thank you very much for listening to me. Over.
Well done. Thank you, Bosco. Thank you for that wonderful presentation. We appreciate you taking the time to go through the results with us. At this time, I know that Jimmy has been reviewing and collecting some questions that we have had in the chat box. I encourage you to keep asking questions there. And we would prefer you to ask your question in the chat box. Jimmy and Bosco, if in your response to these questions, if you could read the question out loud for everyone and then provide your response. And I will hand it over to you.
Okay, thank you everybody again, and thank you for the big interest. We are watching the chat box, and the questions go as follows. The first question is just 1 minute. One minute. The first question came from Gausi. It reads, Agaba, kindly give more light on the sampling. Are we saying that the estimates are possible by region or well by district for IRS districts, or where the IRS districts a block or stratum? Could we have James to take up this question? James, please. Is James still on?
Maybe Stephen.
Oh, okay, Stephen, please,
Yeah.
could you?
Yeah, thank you for the question. I'm Stephen from the Bureau of Statistics. The explanation given was that we had 15 strata, which were the district groupings with Kampala standing alone. And within additional strata that we had IRS districts. So it is not that we look at one district as such and we have estimates for that district, but we would take a combined group of IRS districts that had been spread, and then the estimate are for that group. It is not for an individual district. It's for that group of districts, and then for the other strata, the regions, is for a group of districts. So if we talk of West Nile, the estimate we are giving is for the districts of West Nile. If we talk of Busoga, then the estimate for a certain variable we are talking about are for Busoga. So we don't have any district estimates here. It is for a district groupings. Even for IRS, it is a district, the IRS districts that were grouped together. I hope I'm clear.
Okay, Gausi, as standard, of course, as you have heard, normally there are strata which are chosen. They are chosen wisely. Somehow they're the same strata as in demographic health surveys. It helps us to initially the MIS strata were not aligning with the DHS surveys, but in this particular one, we decided to align them so that we can have cross-sectional data sets every 2 years. Since DHS are done almost every 4 years, and in between their MISs, some of the measures can be closed. And if we use statistical tools for, interpolation, we can easily have a continuous thing. So we stopped at such region. But of course, data sets going down are there, but they may not make good, they may not have a good statistical power. DHS MISs, you know, are meant for a particular purpose. They are not meant for going up to that level of at the lower level. If we need that, we need some more additional surveys. The next question is from Godfrey, and he's wondering that what could be the factors for high percentage of low HP in central Uganda, especially Kampala and Busoga. Does anyone want to take this up? You can put up a hand, or no hand is coming up. Well, the factors were not explored in this because that was not the purpose of the study. The purpose of the study was just to establish the level of HB. But we know HB is so related both to malaria, but also closely related to other nutrition determinants. Now, it is of course very, as we know, Kampala has very low malaria. And then if you see also very low HB, it can be very controversial. But Busoga especially, we know, has very high malaria and very high poverty levels. But Kampala also, although there is low malaria, being a metropolitan place and a high level of inequalities, this is expected. But this needs, we can look at, we can corroborate the information here with other things like nutritional surveys, which have explained this in detail. In this particular study, the reasons were not looked at. Can I go ahead? The next question was from Pamela Kakande, that why did the 2016 UDSS show a lower rate for ownership of ITNs, and the current rate is also lower than that of the previous MIS? And so I believe it is not a data collection method different. Why is this so? Okay, very good question. Now, nets have a lifespan. The manufacturer claims they have a lifespan for 3 years. So if nets are given within 3 years, they would have outlived their usefulness. So in around the world where routine net access mechanisms are not fully functioning, there is a recommendation to do a universal distribution every 3 years. So we did one in 2016-17. We had done one earlier in 13. And then again, after doing the net distribution, there is attrition. It is now known that households lose their nets about 20 percentage points every year. So if you give this year and you get a coverage of, let's say 80%, by next year, the coverage may drop to 60%. By the other year, it may drop up to 40%. So malaria programs have a system of attempting to keep the coverage up from the attrition in 2 ways. One is promoting net use, care, repair, and repurposing. Once communities adopt methods of care, repair, the attrition levels drop. So one of the reasons of the dropping is that this has not worked very well. The other thing we do is we have other routine methods. At the moment, we are giving routine net distribution through antenatal clinics and child health clinics. You know that population is about 9% of the population. So if in a year the coverage drops by 20 and you replace by about 9%, you cannot match the attrition with the replacement. So depending on when the MIS happens, if it happens right after a campaign, you will measure a higher coverage. If it happens much later, you get a lower coverage. So in 2013-14, the MIS happened very close after a net distribution. By 2016, people had been with their nets, that was the 3rd year. So you would expect there was a lot of attrition. So you would get a lower coverage. Meanwhile, in 2018-19 MIS, it was in the 2nd year after a net distribution. So that is the explanation why they are at different levels. I hope I've made that answer. Where do I go? Next, just 1 minute. So Bosco, let me send one to you from Alex. He said, Bosco, it would be good to know the geographic prevalence of the different species of the Plasmodium. I know we have this detail, although Bosco has not presented. He will tell you the reason. Bosco, off to you.
Yeah, thank you very much, Me. So if we go back to the raw data sets and try to do some additional analysis, I believe this information can be extracted and presented. So here we were only presenting the key findings, but that information can still be available. Over.
Yeah, so as Bosco said, we have the information available. This was just meant to release key highlights. We know the parastemia, the parasite by type per strata. It is well known. Next is a question from Simon Kasasa. Did you try to measure comprehensive knowledge of malaria transmission? Yes, we did. In fact, this MIS for the first time went further than that. It attempted to even measure risk perception and intention to act. So that information is available. Next, I believe from Eric, I believe the test and treat approach is part of the 2016-2021 strategic plan. How comes the testing has only increased by 2 percentage points from 2015 to date in children among fever? Is it a reporting issue? Bosco, could you help me with this? Is this question really related to the study or it is a general question? Bosco, off to you.
I think this could be in the category of general question, but of course, in the routine HMIS data, we see very high testing rates. And it's not very clear why the population-based indicator is still very low. We don't know whether it is an issue of sampling but you all know that the testing rates in the DHIS2, the HMIS routine data, we have high testing rates.
Bosco, this is Casa. Let me just chip in. Yes, HMIS is facility-based. Test and treat in facility-based is always high. This is population-based survey. You cannot really expect a high test in population-based survey, just parallel to HMIS. So this is a general question. It can be really discussed, but what you see at HMIS, high testing rate, will never and ever reflect heavily with the population-based survey. Over to you.
Okay, thank you. Stephen, another question. Okay, someone, you can come in.
Dr. Pigo.
Yes, please.
This is Gausi. Just to back up my colleague who had just said, HMIS, remember, the people that are in HMIS are people who are sick, who are coming to facilities. The community-based survey is looking at everybody. It's a sample. So there's no way you expect the HMIS to be anywhere close to the community. Thank you.
Okay, thank you. Stephen, another question for you from Simon Kasasa. That comment on spatial variability. Stephen.
Are you there?
Hello?
Hello?
I haven't understood the question. Spatial viability of what?
Simon, could you come again? What do you exactly mean?
Let me clarify on the question because I haven't understood the question.
Simon Kasasa is not there because spatial variability of what? I think it's not quite clear.
I would like to suggest that we move to the next question, and then allow Stephen some time to gather his response. Thank you.
Okay, the next question is from Tega. malaria prevalence is very high in Karamoja, West Nile, and Busoga. What are the factors contributing to this situation? Okay, you will see when Bosco presented net coverage, for example, it was highest in West Nile, and it has one of the highest, paradoxically, one of the highest prevalences. Karamoja, you saw clearly service access is very low. It has the lowest net coverage, for example, so will not be surprised. But however, we know the contextual factors in these three places. These three places have traditionally been our highest burdened malaria regions. They have high level of poverty, the poorest form of housing, for West Nile, we know has got the following reasons: poverty, poor housing, very high insecticide resistance. In West Nile, it used to be a cotton and tobacco growing area. So because of that reason, they have heavily used the insecticides, especially DDT, which has a cross resistance with pyrethroids. And so despite the high net coverage, it was not, and high service access, it was not translating into benefits. And then the housing is mostly traditional housing with a big eave, so mosquitoes can go in. Again, that area is very hot in the dry season, so people live out. There are a lot of cultural and contextual issues. For Karamoja, it is a pastoral area, and nomadics, they're on the move, very high poverty, very poor housing. In fact, the men and able-bodied people sleep out to keep guard for the animals. So there is no protection from housing and nets. For Busoga, we know very well the issue is very dense population, so efficient transmission, poor housing, and poverty. You have heard this is the third MIS. You would wonder why we have known this and not acted before. Initially, we had very high malaria prevalence, and so we could not, and the concept of stratification and targeting had not yet come up. So we had not focused specifically on this in these regions. But going forward, we are paying a particular attention to this region, and we have made, although we are really mostly one strata, because transmission is happening everywhere, we have come up with a clear implementation design which are relevant to these areas. Thank you. Let me go to the next question, which is from, let's see.
From
Felista.
From Felista, okay. Oh, I missed it again.
The question from Philister is, was there any correlation between low hemoglobin and malaria prevalence?
Hello, can you hear me now?
Yes.
Okay. Could I give that question also to Stephen?
Thank you, Doctor. I think this was not done. This is part of the further analysis. Yeah, the further analysis that can be done to see whether those correlations exist between the two, and any other variables that you want to come into the equation.
Okay. So this is part of the further analysis, and you remember the introductory remarks from UBOS is that the data is now available for us to analyze further and answer all these questions. So we need to take all note of these questions. It is one of the things, and this would have been very valuable if we did this dissemination before the malaria program review, because we have needed to answer all such questions. From Patrick Bongomin, what could explain the low diagnostic testing rate at only 51% in children yet? I think this has been answered. This is a population-based study, and at the population-based, there are people, you know, they seek care with the public, some seek in the drug shop, they just buy and treat, so those ones will not have tested. Some are having home pharmacies, okay? So that is a composite testing rate. And programmatically we need, and you know, because of this, we have shifted more attention now to promote testing in the private sector, and also doing SBCC to households for individuals to value testing. The next question again from Ortega. IPT3 has improved a lot from 17 to 41%, but still low and much lower compared to IPT2. And any reason for this? Mayas, I know you are on.
CASA is good. Is good at.
CASA, could you pick the IPT question?
Okay, thank you very much. Actually, first of all, IPT3 was introduced as a new guideline with WHO recently. So IPT3, you cannot really expect it to be more than this one, because the guideline has been introduced in 2015 and 16, and we start, yes, 2013, 14, and it has been started just to be implemented. So 41 was a very wonderful achievement. Over to you.
Okay, thank you. The next question from Stella is in the same light. Is it possible to for the factors attributing to low uptake of among mothers during administration of questionnaires? Now, MIS has stated has a particular purpose to just measure status. It doesn't go in details of explanatory factors, because it works together with our other M&E actions, others specific and more detailed surveys, evaluations. So Stella, this is one of the things you may want to know. But I know Jen is up. This question, the answers are known, and they have made even some proposals on how we can address it going forward. Jen, would you like to step in to say what are the factors for low IPT uptake?
Yes, some of the factors for the low IPTP uptake, one of the things is that we depend a lot on the antenatal care platform. So commonly you realize that our IPTP uptake will be at the same level as fourth ANC attendance until we improve the fourth ANC attendance. First of all, by working on ensuring that mothers come in early, and then the adherence to the scheduled visits, then we are likely to have IPTP going high. Shortly, we can intervene by introducing the aspect of community IPTP, but also the IPTP3 had challenges, like Dr. Kasa clearly said. Yes, we are rolling out new guidelines, but also you needed to also look at the reporting rate for IPT3. We had challenges with data capture for IPTP3, and that explains why IPTP3 was much lower than IPTP1 and IPTP2. We still have episodes of stockouts, but these are not marked. Actually, they are not stockouts, but they are stock imbalances due to overstocks in some areas and understocks in some facilities. So these are some of the things we're planning to address, and going forward, we believe that IPTP uptake will improve. Thank you. Over to you.
Okay, next is from Patrick. Patrick, by the way, apologies first of all, has been a key person in this study. As you are aware, especially the UK funds were passed through UNICEF. We thank UNICEF. and UNICEF routed it through Malaria Consortium before it went to UBOS. So Patrick was a major task manager, organized most of the meetings, so we thank him. So he should not ask questions and instead provide answers. But I can see he has made just a comment that net access and use ratio approximately 1. And thus, if people have access, they are likely to use net. Yeah, that has been established before, that access to net is a major determinant of use. And the gap between access and use is normally very, very small. And the purpose of BCC is really to close that up together with the good use, care, repair, and repurposing. And we focus on that now. Use together with care, repair, and then repurposing. And next question is, kindly clarify on the percentage. Okay, is someone say something?
Hello.
Go ahead, please.
Oh.
Good morning.
Your mic.
This is Myers. I'm trying to augment my senior's submission on IPTP. And 2, there was another question that went unanswered on HB in Busoga and Central Buganda being low. I think the HB being low could be attributed to the fact that actually it was not typed hemoglobin. But in most of these areas, there is what we call nutritional anemia, which is of course coupled with the hemolysis that takes place with the malaria, could give it a very big picture. So I think until we type the type of anemia that there was in Busoga and Central, given the nutritional status of these areas, they depend mainly on matoka, which is more of potassium and zinc. We may not totally attribute this low HB to malaria. So there's need for us to type the anemia so that actually we conclusively attribute it to the malaria attack. Over.
Okay, next from Alan, said, kindly clarify on the percentage contribution of malaria species among species causing malaria. PF contributed to 97. I think you want to say P malaria 10%, 2.1 and 9 for mix. Bosco, could you clarify that?
Thank you very much, Jimmy. So I think what Aaron is saying, we said we detected all the 4 species of Plasmodium. And then she's wondering, I think, why the proportions are not adding to 100%. So, Julia, we had this discussion, I think. Do you want to say something about it?
Sure. Hi, this is Julia Fleuret with the DHS program, who helped support the Uganda the 2018-19 Uganda MIS. And so these are not mutually exclusive results. So some of, for example, some of the falciparum infections are co-infections with malariae or uvale or vivax. So that's why the overall, it's not adding up to 100% because these are not mutually exclusive results.
Okay, could I have the screen back?
Jimmy, I am trying to show the slides when people ask questions about specific data.
Okay.
So please go ahead with the next question. Thank you.
Okay, I got it. Oh, I missed it again. Just 1 minute. I think next is Yeka. Let me see if I've not missed. Okay, that's the. It is slightly over a year since the survey was done. There was a malaria upsurge in the following year in Uganda following the survey. Don't you think there is an increase in the burden of malaria now? Yes and no. We know MIS is cross-sectional, but if they are done over a number of years, we cannot tell exactly what is happening in the gap between the years. But we normally join the we join the points, as has been shown with a smooth graph. However, we know it is not the only way of knowing what is happening in our country. But first of all, we know also very well that prevalence and incidents are not related, especially when you are still very high burden. The prevalence cannot tell exactly what the incidence is, although there are statistical ways of doing it. And then the points in between the MISs are using modeling tools. There is some Simon, you are on. Can you help me? You're able to normally tell what is happening in between when you have a number of other parameters. If we capture like the incidence and a number of parameters, we can. So yes, and all biological systems, they really play. They are not straight. What is important is the direction you are taking, the trajectory. Is the trajectory flat? Is it upwards? Is it down? But along the trajectory, there will be some play, which should really not be a problem. Of course, we know we are working towards a really more smoother trajectory. So we shall measure again in, is it 2021? And 2022.
21, yeah.
2021, yeah. But yes, in between the MISs, things can change because biological things play. The next one is from Alex. Most of the outcomes are for public sector. Were there any aggregation by sector like private, low? No, it was not for public. It is a community level survey. It is a community level survey. So that is what is happening in the country. A total of those who are seeking care from the public, private, and home. So it is a community level. It is not a facility-based survey. Next is from Stella again.
Jimmy, I just wanted to interrupt here and clarify. Within the final report and the data set, we do have source of treatment for children with fever in some of that. So we do have public-private disaggregation among where they sought care that is available.
Okay, good, thank you. Do we have correlation data on net use and sleeping space and structure? Stephen, off to you, that one. Okay, Stephen, we can't catch him, but housing also was captured. So once you get the data sets, you can do analysis to answer this particular question. Okay. And in the detail, I think net use by level of wealth level, which also correlates to housing, was done. So the upper quantile, how is net use in them, the lower quantile, this analysis is available in the detail when eventually made available. I hope that is okay. Next, thanks for the presentation. Do we have plans for dissemination in the sample regions, for instance, at district level? Relatedly, what is the dissemination plan at local? Now, this is national dissemination. There is a plan for regional dissemination and district dissemination. We have proposed that we hold on to do it when lockdown ends. But since we are now getting to understand that this is a new normal, we shall discuss if we really wait or we also do a digital dissemination. In any case, right now as a program, we have agreed any presentation we are making to any group, whether you have gone on SBCC, whether you have gone on LLIN, you start by disseminating this. You also disseminate our new policy. You also disseminate our new strategic plan. So there will be no training or sensitization package approved without the introductory parts first speaking about where we are. Otherwise, then we have just done this to self. So yes, we are going to make sure this information reaches up to the lowest level. From Myers, the net ownership in West Nile at 92, Busoga at 80, with central malaria prevalent results give us a challenge or whether we understand the enemy we are dealing with. I think this is a comment. Busoga has a lot of sugarcane plantation, West Nile tobacco, pesticide regularly applied. I think we discussed this. Pray the next round of insect resistance studies are employed in these areas and find out the susceptibility. Just to add on to Myers, we have tried to reposition our sentinel surveillance sites for insecticide susceptibility so that we have information from all these suspicious areas. Again, USAID PMI is supporting a study which should be starting now, except of course now the COVID phenomena, a housing study in Busoga to understand the contextual factors in Busoga further. So yes, that is additional studies are ongoing for us to see what we're going to do. From Patrick again, given the low prevalence and high malaria incidence experience, what factors should we address in order to get real benefits of low parasite prevalence? Patrick, please answer your own question. Patrick, are you there? Okay, Patrick is not coming. As I said earlier, there is very little relationship between prevalence and incidence. So measure of incidence is very, very important. You know, when we did our strategic plan, we agreed we are going to do micro planning at district level and we tailor interventions. Now, these are what we are showing are averages. But when you drill down, you will understand that many of these cases are coming from very small areas, foci. So going forward, what we are going to do is to focus on where many of these cases are coming from by further granular analysis, either of this data or by line listing of records in our HIMS. So that you say, in this area, if we are having cases, which geographical areas are contributing it? And then looking further in those geographical areas, what is driving it? Is it an underserved place? Is it having breeding areas? Is that area having lower coverage of nets, for example? And then we address it. So this particular question was seriously looked into during the malaria program review and the strategic planning. And we have agreed going forward, we are moving away from one size fits all. We are moving away from blanket coverage and we are moving towards targeting. And I know Patrick would have put that better if we got him. Would anyone like to back me up further on that?
Really, my purpose, Jimmy, was for you to clarify the way you have said. I have no addition.
Bayo here.
Yes.
Hello, Bayo here.
Yes.
Yes, Bayo, go ahead, please.
Hello.
Yes, Bayo,
okay,
go ahead.
Thank you very much. Again, like we know, like Jimmy has explained, the Malaria Indicator Survey focuses on a particular age range. And we also know in Uganda, we've been seeing a pattern that actually shows that malaria is being there in school-age children, people that are above 5 years. So all these have been factored as part of the findings in the MPR, the program review, and have also been taken care of. There are several factors: age, where you live, wealth, and so on. And in Uganda, the geographical, the weather, the climate situation also affects. So that's to answer Patrick's question. And I know he knows that all these factors have been taken into the strategic plan just updated, just to buttress that. Thank you.
Thank you so much. Sorry, now I'm on, but really that was the purpose of the question, because we said we have already used this in the.
Hello, everyone. This is Sally. I think we lost him. It was dropped. We have we have about 30 minutes left in the webinar. We will take a few more questions. So Jimmy, please continue. And then we will share some links with the UMIS publications.
Okay, perfect. The next question is from Kennedy. He says there is high net coverage but low net use. Probably he thinks because of SBCC, and that what are we going to do differently? Again, we looked at this, and in our strategic plan, we said we agreed that we are going to deepen chest malaria. And by deepening chest malaria, we're going to shift to risk perception and intention to use. And we have, based on the mass action against malaria, come up with how communication is going to be structured. We have looked at the key people we need to focus on to communicate to, which are one, health workers, because health workers are not supporting us. They are just treating malaria cases and they are not supporting us with the driving change. We said we are going to focus on caregivers. We're going to focus also on men, and Rukia will help me. I think leaders, communicators. So yes, we have completely changed our SBCC. The SBCC we had before was not bad, but it was good for that stage of malaria programming. Where we have reached, we need to more now target and tailor, depending on what is on ground. Next is from Dr. Yek again. There is variability in malaria burden across the country. Comment on whether we still need the same approach to control malaria, since some regions have reached pre-elimination level. This matter was heavily discussed in the strategic planning. Initially, we attempted to zone the country into 3 strata, but later we are advised that given high vulnerability and receptibility, and given return on investment, and given that resources are not enough, it is not wise to invest in elimination, because elimination is so expensive and you will avert very few cases. I know Gausi, this is one of his favorite subjects. He will come on. So we are told we should consider Uganda as 1 strata. What we need to change only is delivery mechanism. We contextualize delivery mechanism according to geographical and other contextual factors. But in the very low area, we agreed we attempt to set structures and to learn a possible design for elimination. We are going to look at this again in 2023 when we are having a midterm review, and hopefully by then we shall have another data set of MIS, and then we see if we attempt sub-national elimination or not. So at the moment we agreed we are not going to do any sub-national. We shall still focus on accelerating burden reduction, but in different areas, we tailor interventions and contextualize them. Yes, you are reminded to register, please. Next, where the participants with gametocytes only considered to be malaria positive. Sam, that is your question. You asked the question, but the answer is from you. You were the one leading the lab team. Sam, please answer that question.
Sam Usobia, are you there? I think the question for you is whether you counted gametocyte carriage or you just did asexual stages only. Did we include those gametocytes in the count?
That's why I wanted the clarification, because I could see the presentation was on species only, leaving out the gametocytes. So I didn't know who did the analysis, whether he also considered the gametocytes to be positive, but they were counted in the raw data.
Julia, do you have an idea? What did you count and analyze?
So I also thought that Dr. Sam would be the one to be knowing. Perhaps this is one where we can come back later, because I think I need to reach out to Shonda.
Okay, so there's some in-house work for us to do on,
Yes.
on that. We are going to do it, and we shall inform the others. And then from Imelda, this is our chief in UBOS. What explains the high hemoglobin level in Karamoja subdivision? I don't know. Who would like to help us on this? Oh, this is, we know that area has a lot of malaria. We expect it, being nomadic, to have nutritional challenges as well. So do they have some genetic advantages? Bosco, do you have an idea?
Hello.
I know UNICEF is doing a lot of nutrition work there. Yes, Bayo?
There have been a lot of studies. I'm not too sure of the situation in the Karamoja region, but we also know that beyond, don't forget that Karamoja region is in the semi-arid area. Yes, very high malaria, but the pattern of nutrition, we shouldn't forget. Sometimes they are nomadics, they move about, they do very heavy on milk and milk products. That could be a factor. They may go so much on vegetation that could add value to, and there are some other sociocultural practices that could also help with their HB situation. I'm saying that no specific information from Karamoja, but elsewhere, with studies in children and traditional practices, this has been seen before. Thank you.
Okay, thank you from... Okay. Yeah, Bosco, go ahead.
I've looked at the figures critically, the figures presented. Anemia prevalence in Karamoja is 13%, which is the highest. And yet Karamoja also had the highest malaria prevalence at 34%. So high parastemia and high anemia levels.
So they are not controversial, not disproportionate. Okay, thank you. Have we considered implementation research approaches to eradicating malaria? No, we have considered implementation research approaches to malaria elimination, not eradication. We have considered, it is there in the strategic plan. Draft strategic plan. I need to add that word, draft. We have not concluded. So I can see from this meeting that we have not had full participation in the strategic plan. So I encourage all of you to read through, and I know we are going to hold one or so meetings to conclude it, so that we can put some of these issues in. It is one of the major uses of the MIS. Next from Allen Semambo, in addition to 51% testing rates call us to improve management of malaria in the private sector. Yeah, that's a comment, is true. And we are working on it. We have developed a private sector strategy We have now a private sector working group. They are the only working, following SBCC, which has been meeting. The rest of the working groups, including CIMEO, have gone in a lockdown when there is technology. I've not had CIMEO meeting, although this is a CIMEO activity, but SBCC has been meeting every 2 days, and private sector has also met. So as we said earlier, this is a new normal.
The team is not true. Case management has been meeting all the time.
Okay, case management also has been meeting. So the issue is CIMEO. Okay. Noah, you have been so quiet. That is good. It has prompted you to speak up. How are we going to deal with airline efficacy issues in West Nile? So again, Patrick, you know, in our strategic plan, we have agreed that we are switching completely to new generation airlines. I think that's what the country has decided, to switch completely to new generation airlines. So the issue of susceptibility will be addressed. Also, please, let's read the strategic plan. I think, Bayo, you have made a comment on test and treat. I see Ortega has made appreciation.
We'll just take a few more questions, Jimmy, as we finish this webinar.
I think most of what is coming now are comments and people answering even the questions.
Okay, so are there any? If there aren't any other questions in the chat box, we could take.
Almost no questions now. These are all comments.
Okay, great.
Jimmy, sorry.
Yes, Bayo? Yes.
On the implementation research, the country in 2016 developed a research agenda for malaria. And in it, several issues were considered. With the result of the Malaria Indicator Survey, we might need to look at that agenda again and see some of the issues that we flagged, like you said correctly, during the program review and the development of the strategy. We might need to take a look. Eradication, I don't think Uganda is ready, like Jimmy said, even for programmatic elimination. Eradication based on the recent WHO guidance, which was shared early in this week, we are still far away from this. However, we can use that document for many of the visibility scenarios that were done, but definitely not for eradication. But again, Uganda may be there sooner than we think. Thank you.
Hello, Jimmy. Can I say something?
Yeah, please, go ahead.
This is Patrick Okoma. One thing that needed to really come out very seriously in this indicator survey is about the quality of malaria services in the refugee setting. Contrary to popular belief that malaria control in the refugee settings for so many reasons is so low, this MIS actually said in Uganda here, refugee settings were managed very well in terms of malaria control. And there were a lot of gains regarding preventing malaria in refugee settings.
And that
Jimmy,
is right? Yes? Yeah,
Yes.
Noah, go ahead.
Yeah,
No,
thank you so much.
it didn't come out as
a key finding.
Discussion, yes. It has not come out in the discussion as a very, very key finding. Where the
And that was the reason why we made them
yes.
An oversampled kind of strata on its own. Yeah. Noah, go ahead, please.
Yeah, thank you so much, the presenters, and very interesting. And I've listened and very much. But the most important thing is that after MIS results and dissemination, then what? Because there are many areas where we need to be answering the whys, and the political heads, all of them need the whys, because the numbers, yes, they may not tell much sometimes, because that's why even outside of here giving some suggestions for Karamoja, but we are just guessing sometimes. So we need to maybe later to incorporate what follows that why, maybe a qualitative analysis of what results we are seeing to know, to answer the whys, and that will help us. Beyond that, another point is, yes, we can agree. I know those it will take another day, but the results are showing us that some districts have more malaria than the other, and we cannot underestimate those findings. So, and what does it mean? It means without stratifying the country, the results are showing us that it is already stratified in a way. So, are we going to be giving the same commodities to Kampala and the same commodities to Gulu? No. Why? Because the stratification doesn't mean only that, means also resource allocation, resource, all those things need to be thought about. Yeah.
Okay, that is taken.
Yeah, and that's it. Those are my points.
Yeah. Any other comments? We are about to wrap up.
Jimmy, this is Sally. I think we can wrap up this session if you want to give some closing commentary, and I have a couple of other slides to share with everyone.
Okay, I'll just do in 2 minutes. Just, of course, to thank everybody and to say this is the beginning. As I said, we attempted to use the findings in our program review and in our strategic planning. The program review is complete. The strategic plan is still a draft. So for those who missed the opportunity, they have opportunity to look and see to what extent the observations here have guided the future direction. And we update accordingly. Related to what Noah has said, the idea of this is to have a further dissemination and to come up with things which need further examination. As Bayo said, the operation research agenda is a living document. We keep updating it. I know when we are doing the strategic plan, we also listed what we need to understand more, but it's a living document. So I think what is important is how do we take this forward? Do we actually wait for lockdown to end and we do face-to-face, or we start some detail looking into this electronically and also dissemination? I want us to think about this. But also I want to take this opportunity. We know this is World Malaria Week, and that is why we have scheduled this now. Because we have been worried from the beginning that all attention went to COVID, and that's why we came with the term, mosquitoes are not on a lockdown, they are not in a quarantine, and the disruption of livelihood and services can worsen malaria. But you can see it has even disrupted those whose business is to work on malaria. So we need to use this time of World Malaria Day to energize ourselves, and we get back to business. I know most of you have been in business, but those who have joined us today, we all get back to business. Tomorrow, this is an announcement. At the same time, we have a very important webinar, very, very important. You know, every World Malaria Week, we do a malaria scientific conference, which Maya says baptized colloquium. We cannot do without it. It's going to happen tomorrow. This time it's going to be international. We have so many people who are joining to give us what is happening in other countries and what people are doing. So tomorrow, 3 o'clock, please join in. The link, if it has not yet been shared, will be shared. Today we went up to 100 and I think 6 participants. the link tomorrow can carry much more, but we can also be in groups. So I look forward to seeing you tomorrow. We have produced a lot of digital materials. We request you to share them heavily so that this World Malaria Week and the day on Saturday doesn't move unceremoniously. We are thinking of a tweet press conference on a live chat on Saturday. We may set it up on our hashtag Chase Malaria to Zero and hashtag AskOpigo. We are likely to carry it live on Saturday. We shall also inform you tomorrow so that we can engage the wider public. Thank you. Julia, back to you.
Thank you, Jimmy. This is Sally. I want to thank everyone for spending their afternoon, morning with us today. As there have been many questions about what next, why, how do we take this forward, I would like to share 2 more slides with you of some valuable information that you may use in your analysis and dissemination. We do have a key findings video that summarizes much of what has been presented today. This video is available on the DHS program's YouTube channel and will be shared if you registered. We will email you a link with the YouTube and other survey materials. And I want to, drum roll please, we do have the, here is the link, the data set, the final report, the fact sheet, the atlas presentation are all available now on dhsprogram.com. I've put the link in the chat box as well, so you can copy and paste. As Jimmy said, COVID doesn't take a break or lock down mosquitoes. So we hope and encourage that people take the time to review the publications that we have provided today. And we hope that everyone has a good and happy World Malaria Day. And we have happy analysis, everyone, as well. At this time, I don't have anything else, but we do appreciate everyone spending this time with us today. I think this was a successful venture. So thank you, everyone, and happy World Malaria Day.
Thank you. Bye.
Thank you, everybody, and bye.
Bye.
Thank you, Dr. Jimmy. Thank you, all presenters. It has been a good meeting.
Thank you.
Bye-bye. Thank you.
Thank you all.
Bye.
Thank you, Sally. Thank you, Jimmy. Bye-bye.
Thank you, Jimmy.
Okay. Bye till next time in the meeting.
Thank you.
Thank you, Dr. Jimmy. Thank you to the organizers. Thank you, Jimmy. Bye.
Thanks, Jimmy, for treating issues very well.